Today we are going to do a head-to-toe physical assessment. My name is Sarah Clark, and I will be walking you through all of the steps for head-to-toe assessment. This is Kylie. She's agreed to be our patient today. So first, I am going to just wash my hands since I'm going to be assessing Kylie, and I just want to first walk you through the steps of an assessment. When you do an assessment, we'll work our way through all of the systems. And you use the 4 methods, which are inspection, auscultate, palpate, and percussion. And you usually use them in that order. There are a couple instances, like for the GI system, that we'll switch up the order, and I'll explain why when we get to that point. Before we start with our official systems, we're first going to check a set of vital signs. So first I'm just going to feel Kylie's pulse here, and look at the seconds on my watch. And you want to count for 6 seconds, and then times it by 10. Kylie's pulse is about 70. And then while you're talking to your patient and assessing them, you can monitor their respiratory rate as well, which is about 16 for Kylie. And we're going to check a temperature. We're going to put a clean sleeve on this. This is a tympanic thermometer. And then you pull up and back on the ear and insert it and press the button. And her temperature is 37.4, which is normal. You can also do an oral temperature where you stick the probe under their tongue and have them hold it until it beeped. And then lastly, we're going to do a blood pressure. You can do it automatically, but we're going to do it manually so we can go over the scale. So first, you want to make sure you have the right size cuff and place it on your patient's arm. There's an artery line where it should go in the center. And then wrap it around, and I'm going to fold it back so I can see my dial here, or you can just move your dial. We'll do that. I'll clip it to your down. Maybe. Okay. So the first time you pump up, you want to feel their pulse, and you want to pump until you can't feel their pulse anymore. For most people, it's around 160, and that's where it is for Kylie. About 160, I can't feel it. So then you let go and grab your stethoscope. Place the stethoscope on the inside of their arm here. And this time I'm going to pump it up to 160 and slowly release it until I hear the beat, and then I'm going to listen for when the beat stops, and that gives you your systolic and your diastolic blood pressure. Kylie's blood pressure was nice and low. It was about 98/60, which is a healthy blood pressure for someone of her age. It's all those half marathons you've been running. Okay, so that covers all of our vital signs, and everything looks normal so far. If you were doing electronic vital signs, you could also measure their oxygen. It should be above 90%, but you can't do that one manually. So the first system we're going to start with is the integument system. So first we're just going to inspect her head, her hair, her skin on her face and arms and legs. And we're looking for any lesions, any discolorations, any rashes, anything like that. If there are any lesions, you want to measure them. And if you are concerned about like skin cancer, you would watch for any lesions or anything that would change color, or they're growing or changing in some way. But I don't see any of that on Kylie here. Her skin looks pretty normal. She's got some freckles, other than that little birthmark on her leg, but everything else looks really normal. There are different categories for skin breakdown if you're getting worried about bed sores. A category 1 is where there's some skin irritation. Category 2 is where there's some actual skin breakdown. It's starting to tear away. Level 3 is where it breaks down to the muscle, and the level 4 is when it goes through the muscle or all the way to the bone. Kylie doesn't have any signs or symptoms of a bed sore or anything. She's not even a level 1, so she's doing great. Next, I want to inspect the nail appearance, both on her fingernails and her toenails. Looking at someone's nails can tell you like their level of cleanliness or self-care, their hygiene. It might give you hints as to what their occupation is, if they're working with their hands a lot, or if they're working like with oil and grease and it can't be cleaned off. Your fingernails should be mostly opaque with a little bit of pinkish underneath it, and should be flat contour. You want to look for clubbing and rule that out, which is when there is an increased angle between the nail bed and the finger. Kylie doesn't have that. And then at the same time, you can check capillary refill, where you squeeze the base of the nail until it blanches and goes white, and then when you let go, you count how many seconds it takes for the blood flow to return and for the color to go pink again. And Kylie's is a capillary refill of 1, which is normal. We'll check it on the feet as well. And again, a capillary refill of 1. Next, after inspecting those things, you're going to palpate. So I want to palpate Kylie's head, feel for any bumps or bruises. Have you noticed any goose eggs on your head, anything like that?
I hope not.
Have you noticed any change of hair texture or hair loss or anything like that?
No.
Okay. Her hair looks thick, it's evenly distributed. She has hair on her arms and on her legs, which means she has good blood flow to her extremities. If you had really shiny skin on your ankles or legs and no hair, it could indicate a loss of blood flow there, and that's why it's not growing. But everything looks normal here. You're also going to palpate the skin and just feel the temperature. It should be warm. And you can test the hydration of the skin by doing what we call tenting. So if you grab some of the skin on the hand here and pinch it a little, if the skin is hydrated, once you release, it'll go back to its normal shape. If a patient is dehydrated and you let go, it will hold that tented shape on their hand. So Kylie's went back to normal, she's well hydrated, and then you can check for any edema or swelling. Usually it's in the lower extremities, but check everywhere. And Kylie doesn't have any swelling in her ankles or feet, and no varicosities or varicose veins or anything like that. The next portion we're going to assess is called HEANT. That stands for head, eyes, ears, nose, and throat. And so first with the HEANT assessment, we just did the head looking at the hair, and then so next we're going to do eyes. And I want to first check, my pen light's in my pocket, for PERLA, which is assessing if the eyes, specifically the pupils, are equal, round, reactive to light, and have accommodation. So first I'm going to just bring this light over to your left eye. When it gets close to your left pupil should constrict. So that's the reactive to light. And you should have what we call direct and consensual reaction, meaning the first time I bring the light to her left eye, her left pupil should constrict, and then the second time I do it, her right pupil should constrict. And they both do, and then you bring it to this side and do the right eye once for direct, and then do a second time for consensual, and both pupils constrict. To test accommodation, I'm going to have Kylie just look at my pen here and just follow it as it gets closer to you. Okay, that's good, and back out. This is testing if the patient's eyes can accommodate between near and far-sighted things. Next, I want to check the cranial nerves 3, 4, and 6. So you do this by, again, I'm just going to have you follow my light with your eyes. I'm going to start in the middle and go right, high, low, back to the middle, and then go left, high, low, and back to the middle. And she was able to follow all 6 of those directions, which means that cranial nerves 3, 4, and 6 are all intact and functioning properly. You want to assess the color of their eyes. The sclera should be white, and they are. And then to assess the palpebral conjunctiva, I'm going to gently just raise her upper eyelid. It's nice and pink, and then the lower eyelid, also pink. And then same on the other side. And the upper eye. Try not to stab your eye. Okay, everything looks normal there. Then I'm going to again get my pen light and have Kylie open your mouth and say ah. Looking at her tongue, her oral mucosa, her uvula should be centered in midline. Everything should be slightly pink. Oral mucosa is a slightly different color than like nasal mucosa, and that's normal. But I don't see any lesions or anything irritating on the inside of Kylie's mouth, so the oral mucosa looks really good. And then next I'm going to check the nasal mucosa. For that I'm going to grab my otoscope and just look, I didn't warn you about this, and just look here and see if I see any lesions or sores or a deviated septum, and then on the other side, which I don't see, it looks good. The mucosa looks intact. You want to be really gentle when you're doing it, the nasal mucosa, because you don't want to accidentally give them a nosebleed. Okay, so we've inspected the oral mucosa and the nasal mucosa. You also want to inspect the visual acuity. So I have a Snellen chart placed on the wall about 20 feet away, and I'm going to have Kylie just read to me that line with the green on it.
P-T-O-C-E-T.
Perfect, and she got those all correct, which means that her vision is 20/20, which is a normal finding. Next, we're going to kind of work our way down from the face into the neck and clavicular line. So I'm going to have Kylie sit up for me, and I'm going to palpate her thyroid. And you can do this best if you come from behind the patient and just kind of feel their throat, the esophagus, trachea, and feel for the thyroid. I'm going to have you look to the right. If they turn their head, you can often feel the gland a little bit better. I don't feel any masses or irregularities there, so that's good. And then next, I'm going to palpate the lymph nodes for tenderness or pain. And you do that by using the pads of these 3 fingers and just kind of working your way down. So first, you can look at me for this. Just a little angle, a little easier. You do the pre-auricular in front of the ears, and then the post-auricular behind the ears, and then the occipital behind the neck, and then the posterior and anterior cervical nodes run on both sides of the sternocleidomastoid. And those are all normal. And then the submandibular and the tonsillar ones, and then the subclavicular down here, they sit in the pocket of the clavicle. Normal nodes are mobile, they're non-tender, and they're pea-sized. All of hers feel normal. Have you had any tenderness or anything in your neck or throat? Perfect, that's all normal then. Okay, next we're going to look at the ears. So first, you can lay back again. So, I'll get my otoscope ready and have you tuck your hair behind your ear there for me. Thank you. You want to look at the outside of the ear, at the configuration, make sure there's no drainage or sores or anything like that. Look at the size and shape. Ears should be symmetrical, sit evenly with each other. And then I'm going to look inside the ear at the tympanic membrane. It should be kind of a pearly white color. If you see any redness or inflammation in the ear canal, or any bulging or redness in the actual membrane, it could indicate like an ear infection or something like that. The easiest way to do this is to pull up and back on the auricle of the ear, and that kind of straightens out the canal. And do that, and then look in here. And I don't see any redness or excessive drainage or any problem with the tympanic membrane. It all looks good.
Look clean.
Looks clean. So then that tests the actual function of the ear. Next that tests the anatomy of the ear. So next we're gonna test the function of the ear and do a couple hearing tests. So I want you to cover your left ear for me, plug your ear, and I'm gonna whisper a 2-syllable word and I want you to repeat it. Good job. And then switch and do it with the right ear, and I'm gonna lean onto this side so she can't hear me as easily. Baseball. Perfect. So she got apple and baseball with ease. The next 2 tests you're going to do with the tuning fork. The first one's called the Weber test, and you do it by ringing the tuning fork, and you place it on the center of their forehead, and I just want you to tell me if you can hear or feel the vibration in one or the other or both ears, okay?
Both.
Good. They should be able to hear it in both. That means they have normal bone conduction of sound to both ears. The next test is called the Rhine test, and you do that by, again, hitting the tuning fork and placing it on the mastoid bone behind the ear, and then I want you to tell me when you stop hearing it or feeling it vibrate when it's on the bone, and then I'm gonna hold it in front of your ear and I want you to tell me if you can still hear it, okay?
Yes.
Okay, and that is a normal finding. They should be able to hear it in front of their ear longer than through bone conduction, because air conduction works better than bone conduction for hearing. Next we're going to move to the respiratory system, and we're going to start with inspection. So as your patient's laying here, I'm just going to pull this down a little bit tighter so we can see your breathing. In a real clinical situation, if you were worried about the respiratory system, you would have their chest exposed, but for the sake of this, we'll keep Kylie gowned. But look and see if they're like breathing heavy, if they're breathing deeply. Look at the size and shape of their chest, their depth of respirations, and any effort that might be going into it. So as we're looking at the size and shape of her chest, we want to determine the AP, or the anterior posterior diameter, meaning how wide is her chest in relation to how deep is the transverse depth of it. In a normal adult, it should be about 1 to 2, meaning the width this way, or the depth is about, the width is about twice as wide that way as the depth. So Kylie's is normal. And then as I'm watching her breathe, you can again assess the respiratory rate, which we did at the beginning. And I'm just assessing if she looks like she's struggling to breathe. She doesn't appear to be using accessory muscles. She's not breathing with pursed lips or flared nostrils or anything like that that would indicate she's struggling to get enough air in. You can also look at the patient's posture while breathing. If someone's struggling to breathe, they'll more than likely be sitting up with their arms propped up in kind of that tripod position, where Kylie's breathing easily in this relaxed semi-fowlers. And her breaths are not too shallow, they're deep and regular and even. So then I'm just going to palpate along the chest wall for any air trapping, any tenderness, any lesions. You feel anything like that? Is that tender at all? Okay. And then I'm going to have you sit up and swing your legs this way, maybe even back a little if you can, so it's almost like you're sitting backwards. And I'm going to test excursion and symmetry, which I'll come on this side. Which means I'm going to place my two thumbs, my hands on her back and her diaphragm here with my thumbs close together in the middle, and take a great deep breath for me, Kylie. And as she inhales, my thumbs should both expand evenly, which means both lungs are expanding evenly. And they were. So that's perfect. While she's facing away from me, I'm also going to percuss the posterior thorax for resonance. When you percuss, you use the middle finger on your left hand and you strike it with your index finger on your dominant hand, which for me is my right hand. And when you're over a bone, you should get a good dull sound. And when you're in an intercostal space or over air, you should have a more resonant sound. So you just kind of percuss along their posterior thorax to rule out any odd air pockets or bone abnormalities, anything like that. And that all sounds really normal. You can also percuss their diaphragmatic excursion, meaning I'm going to have you inhale deeply and hold your breath, okay? So inhale and hold your breath. And so to do that, I'm going to palpate where it changes from dull to resonant, which is about there. Then I'm going to have you take a couple breaths normal. And then I'm going to have you exhale and hold it. And this time I'm going to start from the bottom and work my way up and see where it changes, which is right about there. So that determines just the movement of the diaphragm while she's breathing. A normal range is between 3 and 6 centimeters, and Kylie's is about 5 centimeters, so that's perfectly normal. Okay, you can go ahead. Actually, while you're there, I'll listen. Next, we want to auscultate to breath sounds, and you want to do it anterior and posteriorly, and so I'll just do it while Kylie is facing this way. So there are 5 lobes, 2 on the left and 3 on the right. You just want to make sure and listen to all breath sounds on both sides. So typically it's easiest to just kind of start here and take a deep breath every time you feel my stethoscope. And just kind of work your way down like a ladder. I'm going to have you raise your right arm there, and I'm going to listen to this right middle lobe, which is easiest to listen to under the right axillary. So take a deep breath for me. Okay, and that sounds very normal. All her breath sounds sound clear. Okay, that's good. Now you can lay back in the bed. And we'll listen anteriorly. When you're listening if you hear any wheezing, any rhonchi, any rails, crackles, anything like that. So far it's all sounding normal, but I'm going to repeat everything I just did on the posterior side, on the anterior side. Okay, and everything sounds very normal. Okay, next we're going to do the cardiovascular system, so I'll leave my stethoscope close because we'll listen in just a second. And again, the first thing you're going to do is just inspect. So as I'm sitting here inspecting Kylie, I'm watching for to see if they have any heaves or lifts or visible pulsations. In a healthy person with no heart conditions, you're not likely to see it. So Kylie's looks really normal. And then checking capillary refill would be part of the cardiovascular assessment again, but we did that previously, so I won't re-go through it. But that just tells you if their blood circulation is appropriate through all the extremities. Another thing you can do to check the cardiovascular system is called the Hohmann sign, and this is a very simple way to rule out if the patient has a blood clot or a deep vein thrombosis. And so I'm going to do this by Kylie, just flex your feet towards your face as hard as you can. And is there any pain or tenderness in your calves or behind your knees?
No.
Perfect. So that's a negative Hohmann sign. You can go ahead and relax. Okay, so the next thing we're going to do is locate and palpate the PMI, which is the point of maximal impulse. This is it's located at the 5th intercostal space and the midclavicular line. And it's where, with the anatomy of the heart, where the apex of the heart is closest to the surface and where you can feel the best heart rate. So I'm going to go midclavicular, and I'm going to palpate 1, 2, 3, 4, 5, and it should be right in here. And you can feel that pulse as you walk your way down, and that feels normal. And then I'm going to check her pulses in her radius and her pedal pulses as well. So just use your 2 fingers and check their radial pulses. And you can assess the strength of their pulse while you do this. It ranges from +1 to +4. +1 is very faint, and +4 is very, very strong. +3 is pretty normal. Kylie's are about +3. And then you can just feel in the top of the foot to check the pedal pulses. And they're probably about a +2, slightly less strong, but still normal. Next, I'm going to listen to and auscultate her heart sounds. You're listening for the rate, the rhythm, and the quality. You should hear a distinct S1 and S2 sound. You're listening for any murmurs, if you hear any extra sounds like an S3 or a split S2. The S1 sound, or the lub in lub-dub, is made as the mitral valve and tricuspid valve close, and then the aortic and pulmonic valves closing causes the S2 sound. You want to listen to everything with your bell and your diaphragm. I'm going to listen first with my diaphragm, and you start on the 2nd intercostal space. So there's the 1 intercostal and 2, and that's where I'm first going to start. And I'm going to just listen under Kylie's gown here to get a better sound. It sounds normal, and then you move across to the left side on that 2nd intercostal space, and then migrate down to the 3rd and the 4th intercostal space. That all sounds very normal, and then I'm going to repeat the same thing with my bell. Okay, and that all sounds very normal. She doesn't have any murmurs or any extra noises, and her heart rate is very regular in rhythm. If you have any concerns about your cardiovascular assessment, you can have the patient change positions. You can have them sit up, lean forward, lay on their side, anything like that. You can have them inhale or exhale, and it might give you different sounds, but where Kylie's assessment was normal, we don't need to do that. Next is the gastrointestinal system. So I'm going to have you, if you don't mind, roll up your gown. We'll expose your abdomen here. Perfect. I'm going to lean back just a tiny bit. So while you're inspecting, you're watching to see if you know any pulses from either the aorta or any peristaltic waves. In a very, very thin person, you might see that, but most of the time you don't. And then you're also just assessing their general nutrition, if they look malnourished, if they're obese or underweight. Kylie looks like she's well nourished and everything is normal. And then while you're inspecting the abdomen, you want to see if there are any masses on one side or the other. It should be even across the whole abdomen. It should be either flat or rounded. It shouldn't be like distended or very bloated for their abdomen. So everything looks normal there. And then you also want to rule out a hernia. So I'm going to have you just lift your head forward. And as she lifts forward and flexes, if she had a hernia, you'd likely see a mass in this lower segment, but I don't see any masses, so no hernia. We're good. Next, I'm going to auscultate. Usually you auscultate at the end, but if I percuss and palpate and then auscultate, I might create some false bowel sounds. So I want to auscultate before I do anything to disrupt her abdomen. The abdomen is split into 4 quadrants, so you want to listen in each quadrant for bowel sounds. You want 5 to 30 sounds in each quadrant. And if you don't hear bowel sounds, you need to listen for an entire 5 minutes in each quadrant before you determine that they have hypoactive bowel sounds. Sometimes it can just take a really long time to get all the sounds. So first I'm going to listen on this, get back to my diaphragm, listen on this right upper quadrant. Sorry, it's gold. And vowel sounds sound like gurgling or clicking noises. They're usually low pitched. If they're high pitched, it can indicate an obstruction somewhere. And left lower quadrant. And then right lower quadrant. And I can hear vowel sounds pretty easily in all 4 quadrants, so you definitely ate lunch today. Next, you're going to palpate the abdomen. You start with light palpation, just meaning you gently touch their abdomen to get them used to your touch, especially if you have cold hands or something like that. And feel for any masses or any tenderness.
Nope.
Okay. If you determined any tenderness while doing that, you'd be more cautious doing your deep palpation next. So in deep palpation, you press about 5 to 6 centimeters in. You use both hands. And you can palpate some organs, but you're also assessing just for any tenderness or any masses, anything like that. Okay, nothing? Good, good. Then I want to percuss just the liver to determine the lower liver border. So you can do this by starting just below the ribs and percuss moving up. And where it changes from resonance to dullness is where the lower liver border is. It's usually just underneath where the bottom rib is. When you percuss in general on the stomach, you have a pretty resonant sound because there's lots of air. So if you repeated it on the left-hand side to check the spleen or the stomach, you could percuss, and it's a nice resonant sound when I do it in the center of our abdomen. And then as you get up higher and get to the spleen or the stomach, it changes to a more dull sound. And that all looks normal. You can also palpate and percuss the bladder down low. Normally you can't feel it in a healthy person unless their bladder is incredibly full, but upon palpation here, I can't feel Kylie's bladder. We'll percuss as well. And I can't really percuss it either, which is okay because it just means it's shrunk back down because it's not full.
Nope.
And then the other thing you want to do is assess for a common assessment for appendicitis or something is called McBurney's point. And you do this by doing deep palpation on the lower right quadrant, right above the right iliac crest, kind of halfway between the umbilicus and the outside of the hip. You want to press firmly and deep down. Any tenderness there?
No. Almost tickled.
Almost tickled. If there was tenderness, it could be a sign of acute appendicitis. Tickling is also a normal finding. And then for the genital urinary, we talked about the bladder a little bit, percussing and palpating for it. You can't always feel it, and that's okay. You can pull your shirt down. Get all those layers tucked away. Then I'm going to have you sit up and again swing your legs over the edge of the bed this way. When you're assessing the genital urinary system, you also want to check for CVA tenderness, or the costovertebral angle. And this is, you palpate or percuss in the back where there are difficult to reach structures like the kidneys to assess for any sensitivity in the kidneys. So you do this by placing a palm there and then giving some strong percussion. Any pain there when I percuss?
Nope.
Okay, then same thing on the other side. Any tenderness?
Nope.
Okay, looks good. You can spin around again. If there were tenderness there, I would worry that maybe she had a kidney infection or a kidney stone or pyelonephritis or anything like that. Next, we're going to cover the musculoskeletal system. As you go about this assessment, while you're doing all the range of motion, you want to watch for any painful movements or listen for any popping, clicking, any crepitus, anything like that that might sound abnormal. So as we're doing this, I'll be assessing for that simultaneously. The first thing I'm going to do is have Kylie stand up again. And I just want you to stand here and take a couple steps forward and then backwards. Perfect. And then turn around and face that wall. And we assess her gait as she's walking. She walks evenly with normal coordination, and then you want to assess her posture. She stands upright with her shoulders level. She doesn't have extreme curvature, either like a hunchback or kyphosis, or a sway back, which is lordosis. And while she's standing, I'm going to assess for scoliosis. So while she's just standing still, I'm going to look at her scapula and make sure they're sitting evenly. And then Kylie, I just want you to put your hands together like this and bend over. And as she bends over that way, I'm going to look and see if everything is level as well. If she had scoliosis, there'd be odd curvature in her spine, and one side would sit higher than the other. Okay, that looks good. No scoliosis, you're clear. All right, you can sit back down. I'll probably make you stand up again, but for now you can sit. So next we're gonna assess, I'm gonna sit you up high actually for this one, if that's okay. Gonna assess your shoulders here, and you just wanna inspect, make sure they look like they're symmetrical, they sit evenly, no dislocated shoulder or anything like that. And we'll check some range of motion here. I'm gonna have you flex your arms, raise them all the way up, and then extend them. It's kinda hard in the bed, but do them back behind if you can. You can go out to the side and back. Perfect. And then we can do abduction, raise them out from your body straight to the side, and adduction, bring them in. And then internal and external rotation you can check by bring your hands behind your head, and then bring them down behind your lower back. And that gets your internal and external rotation. Any pain or tenderness when you're doing that? Okay, I don't hear any clicking sensations, so that's good. Next we're gonna do the hips. And actually I'm gonna lay you down for this one and have you just turn onto your right side. We'll just do one hip at a time, or one hip for today, but you do everything for the right and left hip. So just roll onto your right, and I'm gonna have you flex your hip and bring your foot all the way forward. Yep, and then bring it back behind you. That's for extension. Good. That's good. And then abduction, bring it up in the air. And then adduction, can you put it back down? Looks good. And then roll onto your back. And you can test internal and external rotation with the hips, and you do that by bending their knee. And I'm gonna rotate it inward, any pain there, and then outward. Okay, looks good. And again, no pain for Kylie, and no, I don't hear any popping or cracking or anything like that. Okay, the next thing we're gonna do is assess different muscle groups for strength. Strength is rated on a scale of 0 to 5. A 0 is there's no muscle contraction at all. 1 is some muscle contraction. 2 is like when you're doing passive range of motion for someone. And then you get up to 5 means they have active motion against resistance, meaning if Kylie's extending or flexing her arm and I'm pushing down on her, she's still able to extend her arm fully. So we'll go through a couple extremities and test that. So arms, I'm gonna have you again flex your arms, and I'm gonna push on them and flex them all the way. Okay, that's good. And then I'm gonna have you lean forward to do the extension, and you're gonna put your arms, extend them back behind you while I push. Okay, good. So she has resistance, or is able to move her arms against my resistance, which is normal. And then for your legs, I'm gonna have you tilt to your right side again. And pretend you're doing like a hamstring curl against, so bend your knee in that way against my resistance. So this tests her hamstrings. Okay, that's good. And then bend it again and try and straighten it against resistance. Good. That tests the extension and the quadricep muscles. Okay, you can roll onto your back again. To test their shoulders, you can do the shrug test where I'm just gonna put pressure here, have you shrug, perfect. And then we did shoulder, full arm extension and flexion. You can do it to test the biceps and triceps as well. So do a bicep curl for me, perfect, and then straighten your arms. Okay, so everything looks good there. You can also do it on the wrists and ankles. So flexion and extension like that. And then I'm gonna put resistance, try and bend your fist forward, and then push it outward. That's good. And then again in your feet. Push down on my hands, and then lift up against my hand. Okay, so Kylie has like 5+ strength on all of those systems that we just checked. She's able to do all of those against resistance and has good range of motion. The last system we're going to do is the neurological system. So first, I'm just gonna ask Kylie a couple questions. By this point in the assessment, you'd probably know if your patient was alert and oriented just by conversing with them. But Kylie, do you know my name?
Sarah.
Do you know your name?
Kylie.
And where are we?
We are at American Fork Hospital.
Okay, and what day is today?
Today is December 10th.
Perfect, she passed. So she's alert and oriented to the situation, the time, the place, and the person. Next, I'm gonna have you squeeze my fingers with both hands, and you wanna make sure their grip strength is even. Good. If it's weaker on one side or the other, it could indicate a brain injury on that side, but both grips were strong. She's able to follow commands. And then next, I'm just gonna test a couple of reflexes with my reflex hammer here. So the first one I'm going to do is the patellar reflex. So it's easier if you have a patient dangling their legs off the side, but if they're in bed, you can still do it. I'm just gonna have you relax, full weight, just flop your leg. And you wanna strike with the hammer just below their patella in that soft spot right there. Whoa, wow. And do the same thing on this one, let that leg relax completely. There we go. And so that's the patellar reflexes, and then if you're doing the Achilles reflex, you do the same thing, you can just lift it up, and you're gonna strike on the back of the leg right where that Achilles tendon is. And if you get it, their foot should twitch. Was that a reflex?
A little bit of both.
Okay, relax his leg all the way. This one's a lot harder for me. But you should see kind of like the ticking of their feet as you strike that tendon there. Okay, so her reflexes are, well, this knee reflex was like +4 is very brisk, but normal reflexes +2 to +3. So hers were all normal. And then the last thing you want to do is assess their gait, which we did when she was taking a few steps. See if their balance is off and their coordination. And then you also want to check the cerebellar function by doing what's called the Romberg test. So I'm going to have you stand up one more time. Just stand on the side of the bed, and you can face the camera. And then I just want you to close your eyes and stand still for about 10 seconds. And the purpose of this is that if someone has a coordination or balance problem, once they close their eyes, they can no longer compensate and they would probably lose their balance or sway. If they were swaying, that would be a positive Romberg test. But Kylie's able to stand still and keep her balance even with her eyes closed, so she had a negative Romberg test, which means the cerebellar function is intact and working normally. Okay, you can climb back in bed. All right, that concludes the head-to-toe assessment for this course. Thank you, Kylie, for being our patient, and thanks everyone for watching.